Welcome to TRIO Maryland, the Virtual Transplant Journey 2022. We look forward to a program filled with great information and takeaways from everyone who's participating. To open the event, we want to welcome Marty Marin, President and co-founder of TRIO Maryland.
Good morning and welcome to TRIO Maryland's second Virtual Transplant Conference. We are so excited that you are joining us today for this educational event. I am Marty Marin, President and co-founder of the Maryland chapter of TRIO, which stands for Transplant Recipients International Organization. I am a liver recipient from November 2009 at the Johns Hopkins Hospital, and I am very thankful for my second chance at life. After my transplant, I became a volunteer at Johns Hopkins Hospital and the Living Legacy Foundation of Maryland. And then we started working on establishing a Maryland chapter for TRIO. Our mission is to connect transplant recipients with one another, to provide information on transplant topics, and by offering non-clinical support, we complement the services of healthcare professionals. During the last 9 years, we have offered over 100 monthly educational meetings. We have hosted 5 in-person conferences and last year's virtual conference. Transplantation is a journey, and our conference brings you topics and information to help you navigate this new stage of your life. TRIO Maryland is a nonprofit 501c3 organization founded and managed by transplant recipients. We continue to offer great events due to the generosity of our members and friends. With your financial support, TRIO Maryland will continue to provide timely and educational information to the transplant community. Let's take a few minutes for some thank yous. I would like to thank the TRIO Maryland Board of Directors and Ashton Conference Planning Professionals, our web hosting company, for all that they did to create this event. I would like to thank our partners, the Living Legacy Foundation of Maryland, Johns Hopkins Hospital, and the University of Maryland Medical Center. I also want to thank all the presenters for their time and for sharing their expertise on these important transplant topics and for sacrificing their Saturday morning for us. We have wonderful sponsors that are involved in this transplant community, and we wouldn't be here today without their support. Thank you to our sponsors that have helped with this year's virtual conference: TRIO National, Biloxis, Anatomy Gift Registry, Peak Relief, and the National Kidney Foundation of Maryland and Delaware. Don't forget to check out our sponsors and their websites for details on their products and services that they offer. You'll find them on the sponsor tab on the registration platform. Thank you again, and we hope today's informative, educational, and helpful as you make your transplant journey.
What a great introduction and a great way to kick off the 2022 event. TRIO Maryland is excited to be bringing you this conference virtually. A quick reminder about your individual schedule. Please remember that the sessions for which you registered will all have separate Zoom links. You can log into the links 5 minutes before the session starts. If you need support, please email triomaryland@ashtonconferenceplanning.com. You may also text 301-452-6548 or enter anything you need into the chat box. The first session today is preparing for your kidney transplant. Please post your questions in the Q&A tab and we'll share with the speaker after the presentation as time allows. Our speaker, Michelle Morrison, is the nurse manager for the Kidney and Pancreatic Transplant Department at the Johns Hopkins Hospital. She's been at Johns Hopkins Hospital for 12 years and is passionate about educating potential transplant recipients and their families to ensure the best possible outcomes after transplant. Please welcome Michelle Morrison.
Thank you so much. There's a lot of Michelles here today, but I am probably a familiar face for a lot of you. I'm going to go ahead and share my presentation. I am the nurse manager of the kidney and pancreas transplant department, like Michelle said. I'm probably a coordinator for a lot of you, which I know I heard from quite a few that you were signed up for today, which thank you so much for joining. I started in the transplant department as a transplant coordinator and then became lead of the pre-kidney transplant group. And then now I manage the nurses or basically all the team members of our pre-kidney transplant, post-kidney transplant, and live donor kidney transplant. So I am transitioning away from patient care, but that does not mean that I'm not still incredibly passionate about patient education. I truly feel that the more that you understand about your disease process, the better your outcomes are going to be after you receive a kidney transplant. So I'm hoping that today you gain a little bit more knowledge about the process for a kidney transplant, what to expect leading up to a kidney transplant, a little bit about living donation, and a little bit about post-transplant. Many of you have already gone through the evaluation process. Most of you, I think, are already listed for a kidney transplant here. So likely what you're coming here to understand is how to have the best outcomes after transplant. A lot of the information you'll see today, you've probably heard before. I know that I met a lot of you during your 3 or 4 hour evaluation. Or you heard my voice on our YouTube PowerPoint presentation of the kidney transplant evaluation. So that might be why I sound familiar too. So I'm just hoping that you get a little bit out of the presentation today. I'm hoping to finish a bit early so I have time to take some questions at the end, because I really want I want every single one of you to get something out of this. And I also just wanted to take a minute and just say thank you so much for TRIO for having me here. I'm just so grateful for opportunities like this to discuss kidney transplant. And I just feel like that one-time evaluation is just not enough. So I'm glad you signed up today, and I'm hoping you got a little bit out of this. So I wanted to start off with the basics, why your kidneys are so important. Things that they do: they remove waste products from your body. They remove drugs from your body. We're talking more so like pharmaceutical drugs, medications that you take. They help balance your body's fluids. They release hormones that regulate your blood pressure. They produce an active form of vitamin D that promotes strong and healthy bones, and they control the production of red blood cells. So when your kidneys don't work, you do have a buildup of those waste products in your body. You do have a buildup of medications, which is why sometimes your nephrologist will put you on different medications that are not necessarily, your kidneys aren't necessarily needed to flush them out of your body. Balancing your body's fluids. A lot of you probably remember leading up to needing dialysis, or maybe you're not on dialysis right now and you're having a hard time with this, but you have you're very swollen legs, ankles. Sometimes you have a really hard time taking a deep breath because you have a buildup of fluid in your lungs. Sometimes these issues actually lead to hospitalization. Regulating your hormones that regulate your blood, or releasing hormones that regulate your blood pressure. Some of you are probably experiencing either really high or some experience really low blood pressure, different from what caused you to be on dialysis. The hormones that regulate your blood pressure cause it to be super high, super low. And sometimes and your nephrologists are prescribing you antihypertensives, or you could be on medication to keep your blood pressure up, and those are just not working. They produce, your kidneys produce an active form of vitamin D. So you are probably supplementing with a vitamin D supplement right now. That is something that's very important. We'll continue that after transplant. And then control the production of red blood cells. A lot of you are, again, this could lead to hospitalization, but not having a low hemoglobin is because that's likely because your kidneys are not working. We also like to touch on here the differences between CKD versus end-stage renal disease. So CKD is chronic kidney disease. That's usually your nephrologist is staging that. So that means you're not on dialysis yet. Your GFR to qualify for transplant has to be under 20. I'm sorry, at or under 20. So if you're CKD3, your nephrologist might, stage 3, your nephrologist might be referring you for transplant. CKD stage 4, you would qualify for transplant. And then 5, you're probably looking at starting dialysis. Once you reach dialysis, you are at ESRD, which is end stage renal disease. And that's just the final stage of your kidneys failing. You cannot regain your kidney function after your kidneys have failed, and you would need to be started on dialysis. I will say though, it is always, it's a myth to say that you need to start dialysis to get a transplant. We have plenty of patients who don't have to be on dialysis and then they get a transplant. We call that a preemptive transplant. Most of those patients get transplanted with a living donor because most of you probably know once your GFR does hit 20, it is a pretty progressive decline and you will eventually need dialysis. And a lot of you know that the wait time for transplant is quite long. So just important things that I do think it is good to understand. This slide probably looks familiar for most of you if you've been evaluated at Johns Hopkins and you have either listened to our education session or you've been here to see it in person. But there are a lot of people waiting for a kidney transplant in the United States. Almost 100,000 people are waiting for a kidney transplant, and that means the average wait time for a deceased donor kidney transplant is 3 to 6 years. Such a long wait time. Couple things about the wait time. Your waiting time does start from the day you started dialysis. If you haven't started dialysis, then it starts from the day that we list you. So even more important to come in for an evaluation. We will talk about living donation. We'll talk about what it means to be waitlisted. There are a lot of people that die on our waiting list, not necessarily just ours, but overall, like in the United States, about 5,000 people die waiting for a transplant. And it's because a lot of that is just dialysis is really, really hard on the other organs in your body. So our kidneys were meant to function 24 hours a day, 7 days a week. And when you're on dialysis, they're really only functioning for 3 to 4 hours, 3 days a week. So on those off dialysis days, your body, your heart is pushing against a ton of extra fluid. And that can be very, very strenuous on your heart. So we'll talk about reasons why patients who are waiting for a transplant end up not being a candidate for transplant, even though they might have started as a candidate. So we'll talk about that as well. But that's why if your coordinator has ever reached out to you and is trying to get some updated, maybe, for us, cardiac testing is one of the most important things just to make sure your heart is still healthy. And then that was like a depressing fact, but a more positive fact would be that 20,000 patients are transplanted every year, more than 20,000. We just hit our 1 million solid organ transplant, which is really amazing. Just to touch on the benefits, risks, and alternatives, I think it's really, really important to understand that as frustrating as it can be, your kidney transplant team is intended to evaluate if transplant is going to be beneficial for you, it's going to provide you a better quality of life, or it's going to be too risky for you. The alternative to a kidney transplant is staying on dialysis. So if we remove you from our list or we tell you you're not a candidate, the only other option you have would be to stay on dialysis, or you can get a second opinion at another center, of course. But all of the benefits for a kidney transplant are listed right there, but they're all surrounding a better quality of life, a longer survival, living your life without the requirements of dialysis. Overall, you feel better. One thing that we really try to help patients understand is that when you get a kidney transplant, all the comorbidities that you had as a dialysis patient. So if you are struggling with managing your diabetes, your high blood pressure, reasons that you are on dialysis, they're not going to go away. So you still have to be able to effectively manage your diabetes and your high blood pressure after you get a transplant. A lot of the reasons that people are on dialysis is because of that. A lot of the reason people need a transplant is because of those two issues. So we want to make sure that patients understand why they are on dialysis, why they have renal failure, and help manage those after transplant. So that way you're not So that way your transplanted kidney, the gift that we have essentially given you, actually you have really great outcomes that last for a long time. There are so many risks, and I think understanding those risks are one of the most important things that I'll talk about today. First of all, it's a surgical procedure. So anytime you undergo a surgery, anytime you undergo general anesthesia, you are taking a risk. We do a pretty thorough evaluations of your lungs, especially if you're somebody that has chronic obstructive pulmonary disease, or if you're a former or current smoker. We do a very thorough evaluation of your lungs. If you've already gone through the evaluation process, you've probably done pulmonary function tests. Another functional test that will assess like your functional status is a 6-minute walk test. These are all just making sure that your lungs are able to hold enough volume, enough air to when we extubate you. So when we take the tube out during after the general anesthesia that you have during the kidney transplant, that you're able to take a breath on your own. If you're somebody that has chronic obstructive pulmonary disease, or if you have emphysema, or if you're a current smoker, or even a chronic former smoker, these are all put you at very, very high risk for intraoperative or any type of complication during surgery or after surgery. We also make sure on every single patient that their echocardiogram and their stress tests look good. So we do a stress test to determine if you have any blockages in your heart. Some of you have a stress test done and it turns out to be positive. Positive is not a good thing in a stress test. So you want your stress test to be negative. Some of you have done one type of stress test, but unfortunately it didn't show us what we needed. So you had to do another type of stress test. We do usually start with a dobutamine stress test, and then we move to a nuclear stress test. If that nuclear stress test shows up positive, then we move to a cardiac catheterization, which is a surgical procedure. And all we're looking for are blockages in your heart. If you are a diabetic, you are at very high risk for having blockages in your heart. And we want to make sure that you don't have those, because if you are going to go under anesthesia and you do have blockages in your heart, there's a very strong chance that you are going to have a heart attack in the OR, and that would put you at very high risk for complications. So all to say, the surgical procedure is risky, and we want to make sure that you are not going to have, that we can best predict your outcomes. Lifelong immunosuppressant medication is another thing that I really, really want to hit home today, because you are going to be prescribed some medication after transplant that you are required to take for the rest of your life. And if you've heard me talk about this before, you know how incredibly important it is to understand why you have to take these medications. I understand that you're probably prescribed antihypertensives, and maybe one morning you just woke up and you just didn't feel like taking your blood pressure medication. Or maybe you woke up and you noticed that you were out of your insulin pen, or maybe you just felt nauseous. I don't know, whatever. You didn't eat your breakfast, so you didn't take your insulin, whatever the situation may be. None of those reasons they don't work after you get a kidney transplant. You have to take your medications. If you don't, you're looking at episodes of rejection. I just want to explain this a little bit more, because I find that once patients understand the importance of taking them medication, they're not just shoved a bunch of pills. We're not just giving you a bunch of pills and saying take them every day. I find that once patients understand why they have to take them, they're more likely to actually adhere to the regimen. So every single one of us was born with an immune system, and our immune systems were essentially made to fight anything foreign that enters it. So when I say something foreign, I'm talking about different viruses, bacteria, fungal infections. A very common viral infection we've been dealing with for the last almost 3 years is COVID, the coronavirus. So our bodies were born with an immune system to fight foreign things. Now, what your body will recognize this kidney transplant is as something foreign. It was not born with this kidney. It's another person's human tissue. And so our body's first response is going to be to reject it. That's why we're going to prescribe you 3 immunosuppressive medications. We will talk about the specifics of them, but We're going to prescribe you medication that you are going to be prescribed to take every single day. One of them you take twice a day for the duration of your kidney transplant. There will not be a time that we stop your immunosuppressant medications. So just understand that those medications are meant to suppress your immune system. So that way your body does not try to fight it or have an immune response, or also called rejection. Because rejection is not something fun that you want to deal with, and it can lead to graft failure. And when your kidney fails because you decided to stop taking your medication, do you think we will give you a new kidney transplant? Going back to how many people are waiting for a kidney transplant, we have on our wait list at Hopkins, we have almost 1,300 people waiting for a transplant. We transplant 200, average 200 to 300 a year, which is why our waiting times can be upwards of 6 years for transplant. So we want to give patients transplants that are actually going to take their medications. If you're somebody that has a history of non-compliance with your medications, if you're somebody that, because we collect your what we call rounding reports from dialysis. So if you're somebody that doesn't go to dialysis all day, every day, or as prescribed, I apologize, as prescribed. So if you're prescribed to go for 4 hours and you are somebody that gets off the machine at 3 hours because you just didn't feel like sitting there, these are all red flags for us that you're not going to follow the regimen after transplant that we give you. So compliance is so important. I will answer questions at the end, but make sure if you do have any questions about your immunosuppressant medication or the importance, make sure that you tell me, ask them at the end. The risk of rejection and graft failure, I already spoke on, but malignancy and infection. So malignancy is a fancy word for cancer. Our immune system was also, we have an immune system that generally can fight certain precancerous cells, but once we give you the immunosuppressant medication, unfortunately, those precancerous cells can turn into a actually cancerous cell and or malignancy and turn into a full-blown cancer. If you do develop cancer after transplant, you do have to stop your immunosuppressant medications while you're going through cancer treatment, and unfortunately, your kidney will fail. So we try to do our best to determine if you have any precancerous cells. I'm sure a lot of you have gotten colonoscopies if you're over 50. That's to look for colon cancer. A lot of you, if you have the proper anatomy, female proper anatomy for getting a pap smear, you've likely done that. We want to make sure you don't have cervical cancer. If you're a female, or you have, I should say, the proper anatomy for a mammogram, we're looking for breast cancer. Those are the common cancers in the United States. If you're somebody that has a history of cancer, so like if we draw prostate specific antigens, if your PSA level is high, we are going to want you to get a prostate biopsy. Make sure you don't have prostate cancer. If you are somebody that has a history of renal cell carcinoma, we're going to get the pathology report and make sure that it was not invasive renal cell carcinoma. So malignancy is an important thing to understand as well. And so is understanding that you are at very high risk for infection post-transplant because you are taking these immunosuppressive medications. So making sure that you wear your mask, which I think most patients understand these days just after living through a pandemic, making sure that you are vaccinated against influenza, pneumonia, coronavirus, things that can help prevent you getting infection after transplant, which vaccines do a great job of, and so do masking when you're in large crowds. So just to touch on our wait list. So a lot of you are already waitlisted. Like I said, we have about 1,300 people on our wait list. So these are the different statuses, active and inactive. If you're actively listed for transplant, that means you're open for offers. You can be called at any time, but the average wait time is usually about 5 to 6 years. If you're inactively listed, or if you're, we consider that status 7, it means that you're still accruing time on our list, but you're not open for offers. Likely this is due to a medical reason. Sometimes people's GFR is just too high. We don't transplant if your GFR is high. So that's a reason, or maybe they're just dealing with some other medical issues. So I encourage you to reach out to your coordinator if you don't know your status on the wait list. Most patients are active. We inform you of your listing status when we do it. So you can go to your My Chart and look at your letter that was sent to you if you know you're active or inactive. If you're getting kits sent to you, so the tissue typing kits, you are actively listed. We do not send those to people who are inactive. If you're out of kits, I can give you the phone number, but we do have you request the labs, the kits from our immunogenetics lab. And if you're like, I don't know what a kit is, then I encourage you to reach out to your coordinator, because that might mean you're not actively listed and you should figure out how to get actively listed. There are a number of reasons why people are not a candidate, and these are reasons that we actually are discovering constantly while people are on the wait list. It's not just for people who are in evaluation phase. And you can imagine how frustrating it would be to be cleared and actively listed as status 1, and then you're doing your updates, which we would consider your echo, your stress, your CT, and we tell you that now you're not a candidate and we're going to remove you. So advanced cardiovascular disease, I think I touched on this briefly, but just understanding that getting your echocardiogram, your stress test every year when we ask for it. If you don't necessarily need it 6 times while you're waiting on the wait list, we'll tell you when you need to update your testing, but important to keep those up to date. Active malignancy. So make sure that you're getting your yearly pap smears, your yearly mammograms. You should know when your last colonoscopy was. If it was back in 2012, you're probably due for a new one, because usually you get them every 10 years. You can figure out how often you need a colonoscopy. Usually it's based on polyps removed. If you've had more than 3 or 4 polyps removed, you likely need it every 5 years. So if you had it done in 2017, you might want to check and see if you're due for a new one. Important to keep those up to date. You would not want that to delay a transplant. If you're someone who's actively using substances, we'll do a drug screen on you before you get transplanted. So it's best to be forthcoming about this information now. We do still consider marijuana use an active substance, only because we worry about where you're getting your marijuana from and if it's clean. Sometimes people who are smoking marijuana, when they inhale it, we don't know if there was any funguses living on that plant, and when you inhale it, it goes right into your lungs. And then if you have a fungal infection in your lung and you're on immunosuppressant medication, your body's not going to fight that fungal infection, and that could kill you after transplant. All to say as well, you can't smoke marijuana in the hospital. So if you're somebody who's just dependent on it for anxiety or panic attacks or even sleep, you can't use it in the hospital. So if you're somebody that's actively using marijuana with or without a medicinal marijuana card, we need to know about it and just talk about your options. And then last but not least, actually I left one off of here, but so prohibitively high body mass index, that's your BMI over 40. You can calculate your BMI just by Googling those letters, BMI, and it'll make you put your height and your weight in, and then it'll give you your BMI. You cannot have a BMI over 40, and we really like it to be well under 40, just because that's 1, healthy, and 2, you will gain a little bit of weight after transplant. One of the medications can make you gain weight, and we'll talk about that, but we don't want you to be at the highest BMI and then gain more weight, because any BMI over 40 is just overall very unhealthy. And then last, which I left off of here, but is poor functional status. So anybody who, uses maybe an assistive device, so a walker, a cane, a wheelchair, we're going to do what's called a 6-minute walk test, and we're looking for your functional status. So if before transplant, you're not able to pass that, which we consider passing a 6-minute walk test, we consider you being able to walk 1,000 feet in 6 minutes at least. If you're not able to pass that pre-transplant, that probably means you're not going to be very active post-transplant. And if you're not going to be active post-transplant, you're going to be at a very high risk of getting pneumonia and bed sores. So we really want to make sure that our patients are very functional before transplant. Something that is one thing that can disqualify you when you get to the top of the list. We also get it on all of our patients who are over 70 years old. So if you're over 70, we'll likely be requesting a 6-minute walk on you, and you do have to be able to walk over 1,000 feet in 6 minutes. So I hope that helps you understand like the waitlist status and reasons people are not candidates. Like I said, We do a lot of testing when patients hit the top of the wait list, when we know that they're going to be transplanted soon. And sometimes, unfortunately, you can be ruled out as a candidate. One of the things that we're really working on at our center is kind of piloting a re-evaluation clinic. And it's an opportunity for patients to just get additional education on different topics and scenarios that's going to benefit you after your transplant. Because like I said at the beginning, getting an evaluation one time and then not hearing from us until you're at the top of the list, which could be years that go by, is not very beneficial for anybody. So we're piloting a reevaluation clinic. We'll be contacting patients who are near the top of our wait list and trying to get them seen face to face, like I said, for additional education, similar to what I'm doing here, to help give them the best outcomes after transplant. If you're somebody that is not on the top of the wait list and you just are looking for additional education, you can go to our website. We do have a recorded version of what you got at your evaluation. So that's really helpful. You'll hear my voice. I'm the one that I did the recording of it, and you can listen to that. You can also call your coordinator. Your coordinator can set up some additional time to do education, or if you just have some questions for your coordinator, I encourage you to reach out to them on a semi-regular basis, just because it's important to make sure that your coordinator is aware of any medical changes that might be occurring during the while you're waiting for a transplant, so we don't come up with surprises when you're brought in for a transplant. So these are all statuses for your deceased donor transplant. I want to shift gears a bit and just talk about living donation, because living donation is even more important at this point, just because of the extended waiting times for getting a kidney transplant. So you don't have to have the same blood type to get a living donor transplant. So if you're somebody that is blood type, you do have to get a direct donation, you do have to have the same blood type, but we're very active in the paired kidney exchange, which I'm not going to go into too much detail, but just understand that you don't have to have the same blood type to donate. Those are all the areas you can have a direct donor, you can have a non-directed donor, you can do the paired exchange. I also put this little chart in front of you. You see the blue chart, things that are covered and not covered. Everything is covered. So the donor does not have to worry about getting about having insurance or having to pay out of pocket. Everything is going to be covered under the recipient's insurance. So make sure that anybody who's interested in donating to you knows that they will not get a bill or anything and they'll not have to pay anything out of pocket. Okay, everything is going to be covered. The things under not covered: travel expenses and unrelated medical conditions. So for travel expenses, there are definitely ways around this. We do have some government funding that we can pull out of, so that way if somebody is having an issue with traveling here, we can absolutely help with that. Those are just questions that you have to ask. Unrelated medical conditions. So for example, if the donor was getting their workup and they didn't know, they hadn't had a physical in a long time, and then they found out that, oh my goodness, I'm actually a diabetic. The donor team, our Hopkins, we're not going to continue to follow them, because if you're a diabetic, you cannot donate your kidney. And that's an unrelated medical condition. We're not going to provide coverage for them to get treatment here. They would have to go through their own insurance. They can come to Hopkins to get treated for the unrelated medical conditions, but it's not going to be covered under the kidney donor allocation. So just so you know. To discuss a little bit more about how to find a live donor, because like I said, it's more important now than ever to have a live donor. Not only is your waiting time short, but if you know that you're a candidate for transplant right now, and I'm telling you that in 6 years, there's a chance that you're not going to be a candidate for transplant, more of a reason to find yourself a live donor. And don't go out and promote your blood type. Go out and just talk about your story. Share your story. You can type it into Google, the donor app website. It's called the Engage study. You can sign up for this app to tell your story and post it on social media. If you're not somebody that's into social media, I completely understand, but I'm sure you have somebody in your family or your support system that is into social media and can post on your behalf. And sometimes that's a lot of the ways that my patients go about getting the word out there that they need a transplant, is going through social media and talking about their story, having their family members do it for them, so that way it's not them. Donors do not have to go through the recipient to come forward. It can be completely anonymous. So just understand, if you have a pen in front of you, write down that donor number, 410-614-3873. When you're finished, oh, I'm sorry. No, sorry. That's my number. Oh, I'm sorry about that. Write this number down, 410-614-9345. I'll put it in the chat at the end. I apologize about that. 9345, that's the donor number. If you put that number down, patients will just call me, which is fine. I will make sure that they get to the right person. I apologize. The donor team, though, will walk the 410-614-9345. They will walk them through the whole process on getting set up. You can also share this link below. I realize that you can't copy and paste this link right now, but if you were to type into Google Johns Hopkins kidney transplant live donation, this will come up as the first click, and you can share this as well. So when we're finished with this presentation today, if you're somebody that's like, wow, I really want to find a living donor, I highly recommend making a social media post. And all you have to do is put the phone number or the website and just see if somebody comes forward for you. The worst thing you can do is just not share your story. Because I think you would be really, really surprised at how many people were willing to come forward. And not only does it decrease your waiting time for getting a transplant, because it only takes about 6 months to work up a donor. It will remove you from the deceased donor waiting list once you're transplanted, and that opens up that opportunity for one other person to get a deceased donor transplant. So highly recommend trying to find a living donor in whatever way possible, asking your community, your church groups, anywhere that you have a big social gathering, a big social support. And unfortunately, that does mean social media. And I realize a lot of people are just not very into social media, but that is a really big way in 2022 to share your story. All right, so going back a little bit to kidney allocation. So now that you've waited a while on the wait list, you didn't have a live donor, and we've essentially cleared you for a living donor surgery, or for a deceased donor surgery. This is when you've hit the top of the list. You're being called for offers. That just means you are, you're coming up for an offer. It's a good match for you. We'll call you. A lot of people want to know, how long do I have to get to the hospital? So it does vary from offer to offer. I would say an average of 12 hours, give or take, to get to the hospital. We'll tell you when to be here, what time you need to be here. You are going to be told if you're the primary person for that offer, or if you're going to be a backup. So target patient or backup to the target patient. Some of you sitting on this education session right now might have been the backup patient before. And that means we just keep you at home, and we'll say, listen, stay by your phone. We'll let you know if it falls through with the target patient. Some of you on this right now have been the target patient, and you've been called into the hospital, but then later discharged because we did not end up using it. Sometimes because it is such tight time restraints, we don't always have the biopsy back from the kidney. And sometimes when the biopsy comes back, it just doesn't look good. So we'll tell you all of this beforehand, but that is incredibly disappointing to have to come to the hospital and then be discharged. So make sure that you understand that that is a possibility too, until you're in that OR. Or I should say, until you come out of that OR with your new kidney, I would just say be cautiously optimistic about transplant. One thing I did not mention about living donation that's different with deceased donation. With living donation, you have a scheduled surgery. It's usually about a month in advance you know about it. You know the exact time, date, everything you know about the surgery. Whereas for deceased donors, you could be called at any time of the day or the night. That means we could call you at 2 o'clock in the morning or 2 o'clock in the afternoon. And sometimes that's not always ideal. You know, if you have a family that needs to, you know, you need childcare, or you have pets or animals, or you live alone and your house needs to be cared for. These are all just things to consider. Living donation is a really great option for people who want a little bit more of a controlled way to get a kidney transplant, versus deceased donation is a lot of the times out of your control when we call you. And then there's also that chance with deceased donation that, because we don't know how that kidney looks and we might not have the biopsy back, there's a chance we could send you home. That's not going to happen with a living donor surgery. Things I wanted to touch on for after kidney transplant, but please understand that every single patient is so different. Things to understand: the new medications. So you're going to be on tacrolimus, prednisone, and mycophenolate or Cellcept. Some of you have been on these medications before and others have not. There are side effects to these medications. If you've been on prednisone, you know how that feels. You probably feel a little wired. You don't sleep well. This is a medication that you're going to be on for the rest of your life. Tacrolimus, there are some adverse reactions to, side effects to tacrolimus. Sometimes people have pretty severe mood swings. If you're somebody that already has a mood disorder, like a true diagnosed mood disorder, we would want to make sure that you are closely followed by a psychiatrist, because we don't want you to start these medications and have these unbearable side effects and then not know what to do. And then you're going to want to stop the meds, and you can't do that because your kidney will reject. So we have to be able to manage the side effects. So understanding that there are going to be a number of new medications. Those are just the immunosuppressive medications. You're going to be prescribed antibiotics, antivirals, antifungals, multivitamins. You're going to continue all the meds that you're currently on, your antihypertensives. If you're on meds for diabetes, you're going to continue those. So people come out of the hospital on upwards of 10, 15, 20 new medications that they're required to take every day. So you can imagine how important it is to have a really, really, really solid support system who can help you with that. I hope some of your support systems are listening into this right now, because it's just so important to understand why we have to take our medications and to take them every single day to prevent episodes of rejection. The next one is JP drains. So some of my patients have told me before that they had no idea that they were going to have drains coming out of their body after surgery. So we place these drains around your transplanted kidney, because anytime you have surgery, your body's natural response to just part of the healing internally is to you're going to have a lot of extra fluid. So we want to make sure that the extra fluid around the kidney transplant doesn't build up, because that could compress your transplant. So we put these drains in it to help the fluid drain out. So another reason to have a really solid support system, because the person who's caring for you, who's helping you, is going to have to help empty those drains a couple times a day, monitor how much came out of those drains, monitor the color, the consistency, if there's any changes, we need to know about it. So JP drains are not something that is for someone that has a queasy stomach, because they're usually pink tinged. It's not necessarily blood, although it could be, and that would be a concerning symptom, which we would explain to you to look out for. But we would want to make sure that the person caring for you is not squeamish and is able to empty those drains. The hospital stay is about 4 to 5 days, 7 days if you're looking at getting, if you're somebody that has a long hospitalization generally, or if you're just somebody that is getting dual organ transplant, which we'll talk about pancreas transplant in a minute, but an average of 5 days, I would say, in the hospital. So that means that your house, your kids, your dogs, your whoever needs to be cared for that amount of time when you're going to be in the hospital. You will be assigned a nurse coordinator post-transplant. So this is somebody that is going to be able to help you reorder your medications if you need it. If you're having any issues with your transplant, you're going to call your nurse coordinator, and that person will be there to help you with any questions that you need. We do have an on-call team that is available at night. So like when the coordinator leaves in the afternoon and doesn't get back till the morning and you have a problem, we'll make sure that you have somebody to call who can help you in the event that you need help in the middle of the night, because of course that's when all the issues always happen, right? Having a good transportation plan in place. So you are going to be required to follow up with us at the outpatient center. So if you came here for your eval, Jayhawk 4, Johns Hopkins Outpatient Center, the 4th floor, you're going to be required to come to us. At first, it's at the 2-week mark, the 4-week mark, the 6-week mark. But that doesn't mean that you, in between those appointments, you do need to get lab work done. So there's going to be a very strict follow-up schedule that you need to make sure that you have a ride to get to the lab, to get to the outpatient center in the event that we need to see you. If you are a female or a male of reproductive potential, that meaning that you're either trying to have a baby or you are not in menopause, you should consult your transplant team prior to pregnancy, because the medications that you're going to be on after transplant, there's a increased risk of birth defects. And so it's very important that if you are not on birth control, that you get on birth control. And even for males, it's important to make sure that your partner understands that you are on these immunosuppressive medications and you cannot reproduce until your medications are changed. But we usually don't do that until it's about 18 months to 2 years after your transplant. So if you are planning a family, which of course we want you to continue, we don't want this to disrupt your life, but we do want to have a good plan in place. So discussing that with your transplant team is incredibly important. The last thing I wanted to talk about is understanding the longevity of your transplant. So when you get a deceased donor transplant, it can last an average of almost 12 years. After that transplant's lasted 12 years, there's a chance you could need another transplant. This is just the average length that it lasts. There obviously is no crystal ball to know how long yours is going to last, but we have plenty of patients that last 20 plus years. The average though is about 12 years. Living donor transplants on the other hand, generally last an average of almost 20 years. So another reason why it's just important to try to find yourself a living donor, because they do last significantly longer. A lot of my patients want to know what happens when their kidney transplant fails. And to that, I say, let's cross that bridge when we come to it. I think that patient education is important, but I also think that your brain can only hold so much information, and worrying about what you're going to do in another decade when your transplant fails is probably not the best use of your time and your stress levels. Preparing for your first transplant is one of the most important things at this point, that you have not been transplanted, but you're waiting for a transplant. So this kind of concludes what I have to say about kidney transplant, and I'm just briefly going to switch on to pancreas transplant, because some of you are either waitlisted for a kidney and a pancreas transplant, or some of you might qualify and not know that you qualify. So the indications for a pancreas transplant, the most common thing we list people for are a simultaneous kidney panc. This is when your blood sugars, generally this is for somebody who is a type 1 diabetic, okay? So somebody who is in their very, very early ages of life, I'm talking like under 10 years old, you were diagnosed with diabetes and you're likely on an insulin pump right now. Your blood sugar swings from high to low, often without warning. You have frequent admissions to the hospital for diabetic ketoacidosis. The benefit of a simultaneous kidney panc is that the average waiting time for these organs is about a year, give or take. So it's significantly faster way to get a kidney transplant. But like I said, those two indications are important. And we also like to make sure that you are a true type 1 diabetic. There is a test we can do for that. Pancreas transplant alone. So this is something that is performed on patients that have type 1 diabetes and no kidney problems. I don't believe anybody in this session has that, but if you know somebody that is is a type 1 diabetic, doesn't have kidney problems, and they want a panc alone transplant for the reasons listed up here, your blood sugar swings from high to low, often without warning, and then you have frequent admissions to the hospital for diabetic ketoacidosis, those would be reasons we would give you a pancreas transplant alone. And then pancreas transplant after a kidney transplant. So if you're somebody that feels like you would qualify or you are listed for a simultaneous kidney panc, and maybe you want a living donor kidney transplant, we can't do living donor pancreas transplant. So what we'll do is get you the living donor kidney transplant first, and then we will list you for a pancreas after kidney transplant 6 months to a year after you heal up from your kidney transplant. The benefit of that is that getting a living donor kidney transplant can last longer because an SPK or a simultaneous kidney pancreas transplant is going to come from a deceased donor transplant. So, and we remember from a couple slides ago that that doesn't last as long. So benefit of having a pancreas after would be you can get the living donor first, and then 6 months to a year after you would get a pancreas transplant. Like I said, pancreas transplants are generally reserved for those who have type 1 diabetes because type 1 diabetics are usually the patients that have the most problems with their diabetes. A lot of patients that are type 1 diabetics are incredibly frail. Thinning hair or hair loss, diabetic retinopathy where they're losing their vision. They have really poor wound healing because they might have peripheral vascular disease. People who maybe have diabetic neuropathy, so somebody who has numbness and tingling in their digits, their fingers, their toes, and they don't feel when they have a sore starting on the bottom of their foot, then it becomes infected. So lots of problems with type 1 diabetics. And so we want to try to stop the progression of their disease to give them the pancreas transplant, the new pancreas. It doesn't reverse the effects, but it'll stop the progression. And with that, I put my contact information up here. Most of you have it, but feel free to jot it down if you'd like. That's my email address. I answer emails all the time. That's my direct line. You will call that number and you will get my voicemail. It's not a phone tree. So you can call me anytime that you'd like. I do ask that you give me 24 hours to get back to you. There are just days where I have busier days than others, and I do have 2 little kiddos at home. So obviously, I have a 3-year-old and a 6-year-old, so they require a lot of attention as well. So I just ask that you give me 24 hours notice or 24 hours to get back to you. And obviously recognizing that I don't work on the weekends, so I'm not usually in my office on a Saturday or a Sunday. And I also, I don't work too late in the evenings. Again, I have 2 kids. So, but yes, please feel free to jot down that information, and then I would be happy to answer any questions. I think there's a couple questions in the Q&A and then in the chat as well. So I'm happy to answer them. I don't know if I can view them.
Great. Yeah, no, I'd be happy to share them with you. Thank you so much, Michelle. That was great. We did have one at the beginning asking if you're going to talk about liver transplants, which I know you haven't touched on. So let's first go with some of the other questions. The first question was, what's a GSR and what lab test shows this?
Absolutely. So it's not a GSR, it's a GFR, so a glomerular filtration rate. And that is shown on your lab work. You generally get a comprehensive metabolic panel and a complete blood count, also known as a CMP and a CBC. So those labs are really important to monitor, like we talked about, your hemoglobin, your GFR, your creatinine, all of those things are really important to monitor. And then what was the second part of that question?
That was it on that.
Oh, okay, great.
And then I do PD dialysis, but gained 10 to 12 pounds. My transplant makes me inactive. My priority date is September 18th. In Pennsylvania, almost 4 years. Advice, should I get transplant any other location?
This is a very specific question. I usually recommend when you have questions that are specific to you that you reach out to your coordinator, but just to generally give you an idea about weight gain. So anytime we make a patient inactive because of weight gain, it's usually because they're they've gained weight over our BMI cutoff. So if you gain the 10 to 12 over the BMI cutoff, we're just asking that you get back to what you were when you were evaluated. We do understand that PD does make you gain weight, but unfortunately, we don't necessarily, if you're over the 40 cutoff, then that is just too high for a transplant, regardless of if you're on PD or not. So unfortunately, your question about waiting in PA and, you are absolutely always welcome to get a second opinion elsewhere. Everybody has the right to list at any center that they would like. So if Johns Hopkins made you inactive, we have a center right down the road, University of Maryland, you can try. If you do live in Pennsylvania, yes, there's a ton of centers in Pennsylvania. So just know your resources, know the centers around you. And yeah, get a second opinion if you feel like you want, if you feel like we didn't make the right call.
Great, thank you. Next question. I'm stage 3 kidney disorder. Don't want to get any higher. Told watch my diet, exercise, drink plenty of water. Is that it?
So you will continue to go to stage 4 and go to stage 5. This is a chronic disease. You cannot regain your function. There are times that you can slow the progression. I don't think that, so slowing the progression, yes, you can stay on a healthy diet, exercise regularly, stay hydrated, but unfortunately you will progress into stage 4 and then stage 5. So what I would recommend is getting out there and getting some transplant education and then maybe an evaluation. You can get evaluated when you're in stage 3 renal failure. You just won't be listed until your GFR hits 20.
Great. Next, with the newest availability of a COVID-19 booster, does Hopkins have a general point of guidance for getting this additional booster and per CDC conditions for eligibility? In particular, I'm double vaccinated and double boosted, and last booster has been more than 3 months ago. It is generally recommended by Hopkins for those on the active transplant list to continue getting COVID-19 protection boosters.
Yes, that's a great question. So hi, Mr. Gilbert, first of all. Second of all, we are recommending that you get the bivalent booster. We're just going with CDC recommendations. We want our patients, before they get a kidney transplant, to be fully vaccinated with every vaccine that is possible for them to get. So right now, they just released the bivalent COVID booster. We really want our pre-transplant patients to get this because it's your best chance at developing antibodies before you get the transplant. After you're transplanted, unfortunately, there's a very, very low chance that the vaccine will work for you because you're immunosuppressed. So your immune system can't even help make antibodies. So fortunately, before transplant, you do have the opportunity to get vaccinated. So yes, absolutely, we recommend getting the newest vaccine.
Right. So next question. Once you get a transplant, does the schedule for mammograms, colonoscopy change? Do you do it more often if polyps have been found in colonoscopy in the past, for example?
That is a great question. And hello, Miss Cunningham. Nice to see you. So the schedule does not change. We always, we go off of just the regular guidelines, the cancer screening guidelines that everybody goes off of. It's not necessarily different for transplant patients. So we highly recommend getting your mammogram yearly, your pap smear. I know pap smear guidelines change, especially if you've had normal paps. So whatever your GYN or your obstetrician is telling you to get them, and then colonoscopy is the same as that. If you're somebody that has a direct family history of colon cancer, then we would maybe want you to get it more often, but we're just going to go off of the guidelines for the cancer screenings for general population.
Great, thank you. The next question is from Mr. Gilbert. If I'm actively in a dialysis treatment session when I receive a call to come in for kidney transplant, is it understood that I should tell the dialysis tech to immediately stop the treatment so I can go to Hopkins for the transplant?
Likely we would tell you to finish your dialysis session before. That probably we wouldn't need you here that urgently. We would tell you to complete it. But yes, and we also would, if we needed you to stop dialysis at that very moment, we would tell we would talk with them. We wouldn't rely on, we wouldn't make you to tell them that.
Thank you. And our next question, can a kidney from an elderly parent who dies be donated to an adult child?
Yeah, so that's a little bit more complicated question to answer. So you're kind of getting at what would be called a deceased direct donation. So if you have somebody who has passed away in a very controlled setting, so they're on life support and they are, they're intubated, ventilated, they have 2 negative brain MRIs. That's a very specific question. So I'm going to say yes, but there's a lot of layers that they have to go through to get there.
Thank you.
And would be happy to answer that one a little bit more in detail if you'd like to email me or call me.
Next, we have how come some transplant centers use steroids after transplant and some don't?
I would, hi Jay, I would steer clear of the centers that are not using steroids after transplant. It's not very, it is not well researched and supported to not use steroids post-transplant. So do your research and what you're comfortable with. It will be probably decades and millions of research studies later until we're comfortable doing steroid-free transplant.
All right. Then next we have how many registries are available in Maryland and how do you get on them?
Yes, I think this is from Ms. Hargrove. Hi, Ms. Hargrove. You can get on University of Maryland's list, and Johns Hopkins list is in Maryland. We don't necessarily recommend listing at both. To be honest, there's not a huge benefit to listing at multiple centers. What you really should put all of your effort into is finding a living donor, because most of the centers along the East Coast have a really long waiting period. And the way that the kidneys are allocated, the deceased donors are allocated based on how far you are from the donor hospital. So you have to be more than 250 miles away from the donor hospital for it to actually be beneficial to multi-list, because you're going to get the same offers wherever you go. So instead of putting all the time and money into traveling to get to these different centers, and it takes a lot to get listed, all the lab work and the repeating the testing, I highly recommend making sure, going through different organizations to help you try to find a live donor over trying to multi-list is my recommendation there.
And then next question, what are the labs that are done every 30 days while on the active list used for?
Hi, Tammy. So the 30-day testing is what is called their HLA testing or immunogenetics testing or the antibody screens. So what we're doing those for is to see if you've developed any extra antibodies. So when we go to match a kidney transplant to you, we're matching based on your blood type, then based on, in layman's terms, kind of like your genotypes. So how you're genetically made up, because that is important to match as well. And then on the third level, we're looking at an antibody level. So if you're somebody that has antibodies and we know about them, we're going to check them every 30 days because we want to make sure that you haven't developed additional antibodies to what you already have. So that's what we do every 30 days.
Thank you. Next question. Why does it take so long when you have a live donor?
So usually it takes an average of 6 months. I will say that this is driven completely by the live donor. We do not call the live donor excessively. We follow up with usually 2 follow-up calls, and after that we assume that the donor is just not interested. We send them a letter to ask if they're still interested, so we try our best to get a hold of them. But sometimes when there's a delay in getting a donor cleared, it's sometimes just because the donor just is not interested anymore. Unfortunately, we cannot force someone to donate. That's the last thing we want to do. We do not want to put somebody in an uncomfortable situation. So if that is, maybe your donor is taking a while, just maybe they just don't have any interest. If the donor is wanting to call, they can call that number, the 410-614-9345 number. They can call that number and follow up on their status at any time. They'll happily answer questions that they have. The more engaged that the donor is, the faster they get through the process.
Thank you. And then our last question. After the kidney transplant, when is the colonoscopy required?
So many colonoscopy questions. I guess because colonoscopies are not fun. So like I answered previously with how often you would get these tests, we are just going off of general guidelines for the general population. So if you had your colonoscopy, it's 10 years. I would have to look at your colonoscopy to tell you if it needs to be done every 5 or every 10, but we would just want you to follow up with your general practitioner and get it every 10 years, if that was the case. So it's not going to be anything different. If you have, again, patient to patient, but if you're somebody that's experiencing some bad symptoms of diarrhea, or maybe you have blood in your stool, of course you would want to get it sooner than that. So we don't change the guidelines after you're transplanted for the cancer screens.
And then actually we had one more pop in. How long does it take for a potential donor to get an initial response from a transplant team member?
So once they submit their questionnaire, they'll be contacted within 2 weeks, usually sooner, but we usually give the longest is 2 weeks. If they haven't heard from somebody in 2 weeks, then you would want to call back to figure out why they didn't receive your application. The easiest way to guarantee they're going to get your application is if you go online to fill it out and submit it, but you'd want to call and make sure that they actually got it. So if they have your application, they'll call you within 2 weeks. If you don't hear from them, call them back.
Great. Thank you so much, Michelle. I mean, this has been really a great presentation. Thank you for answering all the questions. Thank you for your insights. We really appreciate your time today. I just want to remind everyone that our next session will begin at 10:30 Eastern Time. Please check the event website as well as your email for the correct Zoom link for the next sessions. We also encourage you to visit the Trio Maryland website, triomaryland.org, to learn more about the organization, as well as visit the event website for more information on our sponsors and our speakers. And also, we want to thank the sponsors for making this event possible each year.